In today's session, we're going to talk about a brain attack, also known as a stroke or a cerebrovascular accident, CVA. The definition of a stroke is a neurological dysfunction that lasts longer than 24 hours caused by disruption of blood supply to the brain. The brain requires a continuous supply of blood in order to provide the oxygen and the glucose that the neurons need to function properly. Ordinarily, the brain is very well protected against changes in our blood pressure. There's something called cerebral autoregulation that changes the diameter of cerebral blood vessels in response to changes in our blood pressure so that the blood flow to the brain stays very, very constant. But when there is ischemia to a part of the brain or there's hemorrhaging into the brain, brain cells will die. If the blood flow is totally interrupted, metabolism begins to be altered in just 30 seconds. It's stopped completely in 2 minutes, and the cell will be dead in 5 minutes. There are almost 800,000 Americans annually that experience a stroke. Another way to look at it is that a stroke is occurring every 45 seconds. And so in the time that it takes for us to talk about strokes, there will be many, many people that have actually had a stroke. Stroke kills about 430 people per day. It's the number 4 cause of death behind heart disease, cancer, and chronic lower respiratory disease. But it's the leading cause of serious long-term disability in the United States. Risk factors of stroke include the following. Hypertension is the most important one. Remember back to our coronary artery disease lecture? Hypertension causes that initial insult to the intimal layer of the artery that allows that atherosclerotic process to begin. Transient ischemic attacks, or TIAs, are also considered risk factors. Sometimes they're called mini strokes. It's a warning sign. It's a temporary impairment of blood flow to an area of the brain, and that causes a temporary neurological deficit. A TIA lasts for just a few minutes to less than 24 hours. About 15% of strokes are preceded by a TIA. Heart disease, high cholesterol, diabetes, obesity, smoking and substance abuse, as well as birth control pills, are all additional risk factors, and they actually should look fairly familiar to you. The non-modifiable risk factors are the same that we discussed under CAD. African Americans, Hispanics, and American Indians all have a higher incidence of stroke than Caucasians. Strokes are more common in men, but more women die from their stroke. We have two different types of stroke. We have ischemic strokes. They account for 85%, or actually 87 according to your book, percent of the strokes. And we have two subcategories of ischemic stroke, thrombotic and embolic. We also have hemorrhagic strokes, and it's either an aneurysm or very high blood pressure, or an AVM, which stands for arteriovenous malformation, that cause a hemorrhagic stroke, and they account for the other 13% of people that experience a stroke. So let's talk a little bit about each one of them individually. A thrombotic stroke is associated with that atherosclerotic buildup in the artery, and that leads to occlusion of the artery when the clot forms following the rupture of the plaque. It's the same pathophysiological process as coronary artery disease. We don't have angina as a warning, but sometimes we do have that TIA. Thrombotic strokes are characterized by a slow onset and symptoms that worsen, then improve, then worsen again until finally they have a completed stroke where the vessel is completely occluded. The onset is gradual and the patient is awake. They're experiencing signs and symptoms, but they are awake through this process. And after the stroke has occurred, improvements will take place over weeks to months, but there are certainly permanent deficits that are possible. With an embolic stroke, you have a clot that breaks off from an area in a different part of the body and then travels up to one of the cerebral arteries. The usual source of the emboli is the heart. Remember we talked under the dysrhythmia module about atrial fibrillation and how that dysrhythmia allows a blood clot to form and then potentially travel through and up to the heart. Rheumatic heart disease can also be a source for an embolic stroke. Also a mural thrombi that is represented down here in the picture. A mural thrombi is a clot that attaches to the wall, to the endocardium, the inner layer of the heart following an MI. Other sources include plaque from the carotid artery, even air from a dislodged or an open central line can cause an embolic stroke. Now, embolic strokes develop suddenly, okay? There's a rapid occurrence of the neurodeficits. There's a very steady progression of signs and symptoms. Again, the patient is awake throughout this process. An interesting thing about embolic strokes is that there can be rapid improvement, and that's because sometimes the embolus can break into smaller fragments, and so blood is then allowed back through that occluded artery, and the symptoms may improve or even resolve. With hemorrhagic strokes, again, we have usually three sources. Bleeding can occur either into the brain tissue itself or into the spaces surrounding the brain. We have the subdural space, the subarachnoid space, as well as the ventricles, which are spaces. Blood, when it gets into the brain, acts as an irritant, and the blood flow will be diminished beyond the area that's ruptured, and that also results in ischemia and infarction of the brain tissue. Now, an aneurysm is an abnormal ballooning or a blistering along a normal artery. Aneurysms develop in a weak spot on the artery wall. Patients often report a sudden onset of the worst headache of their life. You also often see nausea, vomiting, photophobia, a stiff neck, and changes in the patient's mental status with a hemorrhagic stroke. Ruptured aneurysms and ruptured AVMs usually bleed into the subarachnoid space. Very high blood pressure can also be a source for a hemorrhagic stroke. Patients that have malignant hypertension or a very sudden increase in blood pressure that can occur with amphetamine or cocaine use can cause a blood vessel to rupture. And when that happens, for those reasons, we usually see the bleeding into the brain tissue itself, and we call that an intracerebral bleed or an ICH. Now, an AVM, or an arteriovenous malformation, is a congenital defect that's fairly uncommon. It's this tangled mass of thin-walled, dilated vessels, as you can see here. Ordinarily, the arteries become smaller and smaller till they get down to those little arterioles that drain into the capillary network, and then the blood comes out on the other side into the venous circulation. But with an AVM, the capillary network is missing, and so those thin-walled veins are subjected to that high arterial pressure, and often they rupture. With a hemorrhagic stroke, the signs and symptoms are usually abrupt. The patient does not remain awake. There is a change in their LOC. They become, they have a deepening stupor, and they become comatose. The deficits are very severe, very frequent. In this day and age, we have CT scans and MRIs which will show us what's going on in the brain, but if we did choose to do a lumbar puncture, the CSF would be very bloody. It's not uncommon at all for patients having a hemorrhagic stroke to have seizures. Again, with that much blood into the cranium, you have an increase in the ICP. The duration is variable, and neurological deficits following a hemorrhagic CVA are very probable. When it comes to assessment of stroke, we can group the characteristics according to cognitive, motor, and sensory changes. So cognitive changes, as I mentioned before, can include a change in their LOC. There can be a change in their spatial awareness as well as their proprioception. Proprioception relates to our sense of place in space. It's our ability to orient ourselves in space without a lot of visual clues. If I was blindfolded, I would still know whether my arm is up or whether my arm is down, even though I couldn't see it, if I have good proprioception. You can see impairment of memory, judgment, and problem solving, as well as impairment of language and math skills. Along the bottom of the slide here you see some words, all beginning with A, most beginning with A. We have a lot of those words in the neuromodule here. Aphasia. Aphasia is the ability to use and also to comprehend language. Alexia and dyslexia refer to problems with reading. And I think you can probably figure out what agraphia and acalculia mean. So basically we have difficulty with reading, writing, and arithmetic. I want to spend just a few more minutes talking a little bit more in depth about aphasia. We have several different kinds. Expressive aphasia is also referred to as Broca's or motor aphasia. Patients with expressive aphasia understand what you are saying, but they cannot respond in the way they would like to. They have difficulty speaking. They have difficulty writing. How frustrating this is for the patient. They frequently speak in short sentences that make sense, but they are produced with much effort on the patient's part. They often omit the small connecting words like is or and or the. They may say walk dog, meaning I'm going to take the dog for a walk, or book to table, meaning your 2 books are on the table over there. Receptive aphasia, on the other hand, is a sensory aphasia. The patient does not understand what you're saying to them. They may speak in long sentences that have no meaning at all. They make up words. Sometimes the stroke patient will have a mixed aphasia that's a combination of difficulty understanding words and speech and difficulty reading and writing, or even global aphasia, which is profound speech and language problems. And so for the patient that has aphasia, here are a few suggestions for communicating with them. The first 5 are especially important for the patient that has receptive aphasia. We want to present one idea or thought at a time. Use simple one-step commands. Do not pretend to understand if you do not, and speak slowly but not loudly. Remember, the patient with receptive aphasia does not understand what you're telling them to do. If you say, I'm going to help you get out of bed, and then we're going to sit in the wheelchair and I'm going to take you to physical therapy, that's too much information all at once. Remember, keep it simple. Now, the last 2 bullet points are especially important for a person with expressive aphasia. The second to the last bullet point says, avoid yes and no questions for expressive aphasia, as the answers are often wrong. But at least they understand you. So if they're saying the wrong word, they can either shake their head yes or no. But remember, it takes them much effort to produce their sentences. So try not to interrupt or finish their sentences for them. Motor changes can include hemiplegia or hemiparesis. Hemiplegia is paralysis on one side of the body. Hemiparesis is weakness on one side of the body. And the weakness or paralysis on one side of the body indicates that the stroke occurred on the opposite side in the brain. The motor nerve fibers cross before entering the spinal cord. The stroke victim might also be very ataxic, and this is a picture of a little girl who is experiencing ataxia. And under here it says, to keep her balance, the child with ataxia walks bent forward with feet wide apart. She takes irregular steps like a sailor on a rough sea or someone who is drunk. So that's a good picture of ataxia. Motor changes can also include flaccid paralysis, which would cause the extremities to fall to the side, or spastic paralysis, which would cause contractures of the extremities or cause them to be in a fixed position. Now, next we have 2 more words beginning with A. Agnosia has several different definitions. One is simply the inability to use an object correctly. But I think a more complete definition is the inability to recognize objects, persons, sounds, or shapes. It's the loss of the ability to interpret sensory stimuli, and it's not because there's a difficulty or a defect with the specific sense, like a defect with our hearing or a defect with our vision. It's a defect with the brain's ability to interpret that sensory stimuli. The brain has been damaged following a stroke. There was an interesting example on YouTube. I'm sure you could find many of them. But there was a man, and even though he could see the silverware that were on the table, he said he had to pick up the fork and feel the end of it before he knew whether it was the fork or the spoon. He just simply couldn't recognize it by looking at it. That's a good example of agnosia. Now, apraxia is the inability to carry out previously learned motor skills. And a good example of that is a patient who, following a stroke or a CVA, can no longer tie their shoes. That's a previously learned motor skill. Motor changes can also include bowel or bladder problems, and it can be either incontinence or retention of either the urine or the stool. Sensory changes can include a decrease in sensation on the affected side, also neglect syndrome. Neglect syndrome causes the patient to be unaware of the existence of the paralyzed side. The patient won't wash the affected side or dress the affected side. The affected arm could be all twisted or caught in the spokes of a wheelchair, but the patient won't be aware of it. Its neglect syndrome is most common in patients who have had right-sided strokes, and so they're unaware of the existence of the left or the paralyzed side, but it can occur with left-sided CVAs also. Pupillary changes can be either dilatation or constriction of the pupils. Ptosis is that drooping of the eyelid on the affected side. And then hemianopsia is blindness in half of the visual field. And the pictures over here show you the different ways that a patient might experience hemianopsia. The first picture up here would be a representation of binasal hemianopsia. The vision is missing in the inner or the medial half of the visual field. With bitemporal hemianopsia, vision is missing in the outer or the lateral half of the visual field. This last picture down here represents homonymous hemianopsia, and that's loss of vision on the same side of both eyes. Following a stroke, we can also have cranial nerve dysfunction. And I don't expect you to memorize which cranial nerve affects each of these different things over here on the right, but just know that, you know, the difficulty that the patient has speaking or eating or with facial movement is because the cranial nerves have been damaged. Now, right-sided versus left-sided stroke. You know, thinking really involves both of our cerebral hemispheres. The cerebral hemispheres work together to help us learn new information, to form thoughts, to make judgments, and to store memories. But there are some things that are more prominent on one side or the other. Now, if you are right brain dominant, you are going to be left-handed. And the right cerebral hemisphere is important for paying attention and for understanding. It's also where our emotional expression comes from. It's also important for those visual spatial skills that we have, such as having a sense of direction. A person who is right brain dominant is good to have when you're trying to locate the car in a very big parking lot at the end of that concert. The right hemisphere lets us think holistically, lets us see the whole big picture. Now, if your left brain is dominant, then you are going to be right-handed. And it's the left cerebral hemisphere that's important for our math and our language skills. And language includes our speech, as well as our reading, as well as our writing. It's our logical side of the house. So let's look a little bit more in depth at the key features of right-sided versus left-sided strokes. So again, I just told you that for most people, the left hemisphere is where our language ability is located. So someone who's had a stroke on the left side will be more likely to have aphasia, agraphia, alexia. Memory problems could occur, not as likely maybe as someone who's had a right hemisphere stroke. Again, part of that reading difficulty is because of visual problems. And the behavior of a person who has had a stroke in the left hemisphere is very slow and cautious. They become anxious when there's a new task that they need to learn. They're depressed and they're angry. They know that they've had a stroke and they don't like it. Now, a person who's had a stroke in the right hemisphere is not quite as likely to have the major language problems, but they could have an impaired sense of humor. They might have a few more memory problems and be disoriented to time, place, and person, and they have difficulty recognizing faces sometimes. Again, because I just told you that the right hemisphere is where our visual spatial skills come from, if they've had a stroke on the right, now they're going to have deficits with those visual spatial skills. Their behavior is different from a person who has had a left hemisphere stroke. The person who's had a right hemisphere stroke can be impulsive. They are not aware of their deficits. They're happy. They smile. They are at risk for injury because of their poor judgment. They deny they have deficits and they overestimate their abilities. So knowing where the stroke has occurred will give us some insight into what to expect from the patient. When a patient presents to the emergency department with signs and symptoms of a stroke, the first thing that we order is a CT scan. And most of the time, the CTs come back as negative. So why are we ordering those CT scans? Well, we said that 87% of patients are having an ischemic stroke, and some of them will be candidates for thrombolytic therapy. But if we give thrombolytics, which are clot-busting medications, to a person having a hemorrhagic stroke, it would be fatal. So the reason for doing that CT scan is to make sure that the patient is not having a hemorrhagic stroke. In patients having an ischemic stroke, the CT scan is much more useful after about 24 hours. At that time, you can begin to see the ischemic or the infarcted areas, and you can also begin to see the degree of cerebral edema that is sometimes present following a stroke. Another diagnostic test that we could do would be cerebral angiography. If a patient has been experiencing TIAs, cerebral angiography would help us to visualize which of the cerebral arteries are narrowed or how much narrowing there is in the arteries. Cerebral angiography would also allow us to visualize any of the vessel abnormalities like an AVM or an aneurysm. If we thought that the carotid arteries were the problem, a carotid ultrasound would allow us to see the degree of stenosis that are in the carotids. We could also do a PET scan or an MRI. After the stroke, those tests would allow us to localize the ischemic damage. An LP could be done in order to assess the CSF, the cerebral spinal fluid. Again, if they had had a hemorrhagic stroke, the CSF would be bloody. Now, blood tests or labs are not particularly helpful when it comes to diagnosing a stroke. We just monitor them post-stroke. And this last slide in this set is a picture or a summary slide of the NIH stroke scale. The NIH stroke scale is the primary clinical assessment tool that is used to evaluate neurological status in stroke patients. It might also be used as part of the criteria to determine whether TPA will be administered to that patient experiencing an ischemic stroke. This is just a one-page summary of it. There are instructions that come with it. The stroke scale is actually fairly simple to complete, and if you end up working on a neural floor, you're going to become intimately familiar with the NIH stroke scale. So this ends this portion of the lecture, and we'll pick it up with stroke interventions in class.